Okay. Hello, good afternoon, and good morning, depending on where you are. Welcome to the Care Economies in Context public seminar series. Today, we have Professor Pat Armstrong, who will be talking about creating the conditions for care. Before we start the seminar, I just wanted to mention thank you everybody for joining. This is a hybrid seminar, and we had a lot of registration, particularly from the for the virtual part of this seminar. Over 50 people registered, and I see that there's about 35 people online currently. For people, for your information, we do have the Spanish translation. So if you need or if you prefer to have Spanish translation, please click on the Spanish translation section. Let me first start this public seminar by giving the land acknowledgement, as we do in most of the public seminars occasions. So I just want to start by saying we wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of Huron-Wendat, the Seneca, the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people and across Turtle Island, and we are grateful to have the opportunity to work on this land. I know, although the land acknowledgement statement might seem quite superficial and performative, but I think it is important to recognize and remind ourselves of the fact that we are all settlers here and that we share this place with many people and living things as Indigenous people, and many animals and plants share this land with us. So the acknowledgement is an expression of gratitude and appreciation to those whose territory we work and live on, and a way of honoring the Indigenous people and all living beings who have been living and working on the land from time immemorial. And I think it is also important to understand the long traditional history that has brought us to reside on this land and to seek to understand our place within that history. Land acknowledgement does not exist in a past tense or historical context. Colonialism is a current and ongoing process, and we need to sort of build our mindfulness of our present participation. So with that, let me introduce you, Professor Pat Armstrong, by first giving you a short biography of Pat. Pat, who I have known for many, many years. So thank you so much for coming. So Professor Pat Armstrong is a distinguished Research Professor Emeritus at York University in Toronto and a fellow of the Royal Society of Canada. Her research has focused primarily on health services and especially on women's work within them, with an emphasis on, in the last couple of decades, on long-term care. Her research has been conducted in partnership with unions, government, community, and employer organizations. Recognizing that context matters and that the condition of work are the conditions of care, she insists on listening to all those who live, work, visit, and manage in long-term care. She has published widely, and we all know this, right? Widely co-authoring such books as Wash, Wear, and Care, Clothing and Laundry in Long-Term Care Residential Homes, Air, Critical to Care, The Invisible Women in Health Services, wasting away, the undermining of Canadian healthcare, about Canada healthcare, and she has also co-edited such books such as The Labor Crisis in Long-Term Care, Care Homes in a Turbulent Era, and The Privatization of Care, the case of nursing homes. In addition, she has published really extensively in academic journals and popular media, serving as expert witness in more than 20 cases heard before the courts and tribunals in Canada, and has been invited to consult and present abroad. Most recently, she served on the technical committee that developed the Health Standard Organization's standard for long-term care, and on Congregate Care Committee of the Ontario Science Table. So with that, I would like to ask Pat to come and talk perhaps about 40 to 45 minutes, and then we'll break for question and answer.
Okay, maybe I can even be shorter if I try. Especially, thank you all for being online or
Sorry,
or in the room. And I want to say I didn't realize that we would have a broader audience. And so I apologize in advance if my references are too specific to Ontario or Canada. And please interrupt me to ask what I'm talking about if it sounds quite confusing. So, and as I was preparing for today, I thought of a story that may or may not make sense to you, but I heard it on the Canadian Broadcasting Corporations a little while ago. They were talking about a security guard who bought a construction site. And there was a worker who left every night with a wheelbarrow covered with a tarpaulin. So the security guard would make him stop, take off the tarpaulin, and all he would find was crumpled paper inside. So at the last day of the construction, he said to the guy, the worker who was leaving, I know you've been stealing something. What have you been stealing? And he said, wheelbarrows. My point here is that often we're not seeing what is right in front of us. And the conditions of work are the conditions of care, something that we started talking about 20 years ago, and it's only now being picked up in various places. But as soon as you say something to someone, it's just so obvious. Of course, the conditions of work, the conditions of care. So that's where I wanted to start. And we tend to start, when we do start with the conditions, with the minimum that are required to get the staffer there, rather than ask what makes the work rewarding, let alone what can bring joy. And we've started more recently trying to look for joy. And too often, we fail to make gender central to our strategies, even though most of those who provide paid and unpaid care identify or are identified as women. And a significant portion of those women are newcomers and are racialized in this country, but not exclusively in this country at all. When we do think about gender, it's often in terms of old assumptions about women's skills, women's place, and women's preferences. Like the assumption that women don't want full-time work because they want to be home with their kids, or that work in long-term care only involves skills any woman has by virtue of being a woman, or that they will take on extra work unpaid because women are innately compassionate. Before I go on to develop what our research tells us about joy, though, and conditions and gender, let me tell you a bit about our projects and methods over the years. I say we, first of all, because virtually all my research has been conducted in teams and in partnerships with unions, community groups, government, even employer organizations. I should also say, by the way, just as a bit of warning, I have no slides. I am slideless here, in case you're wondering. Ito was mentioning the kind of work I've been doing, but it really started with my PhD that after I was involved in the student movement of the 60s, actually, PhD that ended up as a book called The Double Ghetto: Canadian Women and Their Segregated Work. And the research made us particularly sensitive to the gender nature of work, as did our feminist political economy, although we did fail to consider intersections besides class when we did that book. We later studied hospitals, and we started studying hospitals because our daughter broke her leg and was taken by emergency to the hospital. And the first thing they did was meet me at the door and say, "Are you the mother? Well, if you're the mother, this is where you get her water. This is where you can get her a bed." Because her father was standing right there, and they didn't say a word to him. But also, as we sat at her bedside, after I got the bedpan, they asked, well, we started to think about who works here and about how the hospital provides the entire range of women's work, managers to people who do housekeeping, full-time, part-time, the whole, and lots of unpaid work for mothers who come in to look after their kids. But as soon as we started to study hospitals, of course, we realized as political economists that we had to know a great deal more about healthcare and the contexts in which they were produced, the values, the organizations, the power relationships, etc. And at this period in time, the hospitals were starting to cut back on beds, increasingly in this country, defining hospital care more and more narrowly to the most acute needs, and then shipping people out of the hospital into what we may call long-term care, or care at home, or no care, but care that it was expected to be done unpaid and untrained, but at least untrained formally by women in the household. And that in turn sparked our interest in especially long-term care of the sort that is 24-hour nursing care, and care that is funded to some extent, at least, from the public first. So our projects have been, for the last 20 years or so, conducted in 4 Canadian provinces, as well as, because Canada has a federal healthcare system, as well as in Norway, Germany, Sweden, the UK, and the US. And can the translator tell me if I'm talking too fast? Should I slow down?
I think we'll send a message.
Okay, great.
They're posting.
So we were guided by our continually developing feminist political economy, and we were using multiple methods. But the most innovative of our methods, I think, is that we took what we call, I should say, site switching team ethnography. So we would take international, interdisciplinary teams of 12 that included senior academics, junior academics, and graduate students working side by side to observe and interview over the course of an entire day, starting at 7, working past midnight, and doing so over the course of the week. We were, as Ito already mentioned, interested in all those who work, live, visit, manage in long-term care, and in their voices. And if you want to know more about that project and the research, the way we did the research, we have a book called Creative Teamwork. And at the end, Ben's going to put up a slide with all of the references that I am making here. But the top of them is our website, where you can find references to our collective work. When we started, we realized how much we were trained to look for problems, whatever our disciplines and in terms of backgrounds. And these included everything from physicians and nurses. We had a philosopher, an architect, cultural theorist, historians, sociologists, social workers, to name only some of the people who were in our research teams. And as also Ito mentioned, we assumed context mattered, a context that included the political economy at multiple levels. We saw lots of evidence of what Johan Galtung and later Paul Farmer called structural violence, the social structures and institutions that prevent individuals from meeting their basic needs, or equally important, achieving their potential. It's the violence inflicted by the system and the inequalities embedded in the society that structural violence refers to. It's my work here. We also worked hard to find what we call promising practices or ideas worth sharing that could help make life worth living for residents and the work worth doing for staff and families. And we even looked for joy. We talk about promising practices because we think there's seldom a single right way or best practice, especially given how much context, populations, and values matter. Our search included conditions at multiple levels and the ways they are shaped not only by policies and practices and values, but also by ways of seeing. We were looking for the wheelbarrows. So what did staff say to us brings them joy? The three most common, in no particular order, are first, joy can come from developing relationships with residents and families. As one staff member put it, quote, "You've known these people for years sometimes, and you can't become part of their family. Our home is their home. They look forward to seeing you when you come in every day, and if you haven't been there, they say, 'Where have you been? Are you okay? We thought maybe you were sick.' That relationship that you build with them helps you to care for them because you know them on a different level, and you get to know exactly what their needs are and how to approach them when it comes to certain things." So second, joy can come from developing relationships with other staff. Like many other staff, one described, quote, "the connections you make with the people that you work with. It's something you don't get anywhere else, and I truly love it." Another talked about how, quote, "teamwork is important because when you pull together, you get the best outcomes. And when you also work as part of a team, you know it makes life more joyous in a nursing home if you all get along, especially." End of quote. And my third most common reason or basis for joy comes from exercising skills to respond to individual needs. Quote, "It's about making a real difference in my residents' lives. If they are hurting, I can help ease that suffering for the most part. I can make them warm. I can get them something to eat. I can help them find something that's lost." Or as another put it, I get to exercise the entire range of skills, doing something terribly medical to something that is like a hug. And that, she said, I really enjoy. So what conditions support these possibilities for joy? Well, we all know that staffing levels are critical. When we were doing our early research, staffing levels in Norway and Sweden were 2.5 times those in Canada. The Premier Harris of the time in this province removed the very low minimum staffing regulations, leaving the requirement for an RN on duty as the only one left. And in the wake of COVID's devastation, Ontario set a target of 4 hours of direct care per resident per day, a target we have failed to reach although we were supposed to have reached it by now. But the latest research by Charlene Harrington, who's also a member of our research team, concludes that the current level of care needs indicate direct care should be over 6 hours per resident per day. And that excludes the other work usually described as ancillary, like food, laundry, housekeeping. So it doesn't take the whole people, it's the direct care staff. Fewer staff means less time to care, time that is crucial to developing those relationships and exercising those skills, not to mention to prevent the exhaustion and burnout that so many report. They take this exhaustion home. When I asked a group of staff members I was interviewing what it meant, this exhaustion, for when they went home, one woman said, "No sex." I expected, like you, that people would laugh, but they didn't. They just shook their heads. And what an indicator, right, of you have no life. And maybe this helps explain our declining birth rate. And low staffing levels contribute to the violence that workers face, as frustrated residents lash out when they can't get help to the toilet, or when they're eating food all the time that is cold because there's no one there to help. Fewer staff also means more unpaid work for those who otherwise get paid for the job. Because as Donna Baines pointed out, also a member of our team long ago, women especially are not prepared to abandon residents, and they're pressured to stay long after their paid hours are done. It's what UK scholars Hilary Land and Hilary Rose long ago called compulsory altruism. Families, and especially the women in them, feel similar pressure. As we point out in our recent book, Unpaid Work in Nursing Homes, Flexible Boundaries, staff are often grateful for the extra hands of families and volunteers. However, such work done by those untrained for the tasks can have negative consequences, like when a resident ends up choking on their food. And this can cause more work for the staff, work that not only involves stopping the choking and calming the resident, but also reporting on the choking incident and all the other repercussions. At the same time, when the family work is done well, it can undermine the recognition of this as skilled work. But forget joy. While more staff are an essential conditions, higher staffing levels are far from a sufficient condition. Continuity and job security are at least as important to developing relationships and support. According to Ontario's long-term care staffing study, less than half the staff have full-time employment, and many of those working part-time do not have regular employment in the same home. Staff can't support each other. They can't comfort each other. They can't joke, they can cry or whine together if their co-workers are constantly changing, and they are themselves worried about the precarity of their jobs. Teamwork is at best difficult, and so is trust in coworkers. And trust is necessary if people are to share the load and develop relationships with other workers. Moreover, changing staff mean more work for the full-time and regular part-time employees, because they have to teach those new to the place and to the residents. They have to show them where the diapers are. They have to tell them that Mrs. Smith hates peas or she'll spit them at you. Those kinds of things come from being there and from working together. And of course, this is particularly the case with the growing number of agency staff we have seen in Canada. Staff who add insult to injury because they both have more choices about their schedules and they earn often twice or three times as much as the full-time workers. We often hear from the managers, oh, well, the women don't want to have full-time jobs, but in a contract in Ontario that offered anyone on the staff a full-time job if they wanted, found that virtually everyone took it. That meant they didn't have to hire agency staff, their turnover went down, and so did their costs. So sometimes, you know, these sexist discussions can cost you a lot of money. Now, much less talked about than either staffing or continuity is the autonomy and trust in staff to provide appropriate care. The COVID Commission on Long-Term Care in Ontario did write about, quote, culture focused on adherence to rules and over-reporting, but not necessarily relating to the priorities most relevant to the residents, end of quote. Health and they specified health, safety, and well-being. Over and over again, staff in Canada talk about having constantly to count and report, of managers not trusting them to determine if a resident was dehydrated, like me, failing to count the quote, something that is lost that we heard about from the nurse earlier. Sorry. Talking so much, I guess. And this disempowerment can have significant health consequences. As I was saying to Ben earlier, Michael Marmon and his colleagues in the famous White House studies, although they might not be famous to most of you anymore. His study, it was a study of the British Civil Service, and what he found was the people who felt the most stress and were most likely to have things like heart problems are people on the bottom of the hierarchy, the people with the least power, not the people that you picture, that high-end managers that we think of as the stressed out. The new technologies, as well as managerial strategies, can exacerbate the stress. Canadian staff told us about the thin blue line, a line on the diaper that turned color to indicate saturation. Staff were told they could not change the diaper until the color changed, leaving no room for judgment or choice. The thin blue line, not the staff or the resident, would decide, even though the residents were often yelling in discomfort. When we reported this at a press conference in our province, the Minister of Health said he trusted the technology, and he said he'd wear a diaper all day and just sew us. We never heard from him. In Germany, Norway, and Sweden, we did not see such constant monitoring and reporting, or any thin blue line. Instead, management relied on trust, training, and teamwork to ensure accountability, doing so in ways that allowed staff to exercise their skills and feel they make a difference. Staff has time to sit down together each day, sharing concerns and stories without needing to justify the time, doing so in ways that ensured accountability. In Norway, I watched an occupational therapist who was really pushing hard a very frail man to walk. And what we see most commonly in Canada is people who have balance issues at all are put in a wheelchair, and that's where they stay, is in the wheelchair for the most part. But not in this place. And I said to her, "Aren't you afraid that he's going to fall?" And she said, "Well, I'm there to catch him, and my job is to push him to the extent of his capacity so he keeps them. But what happens if he falls?" said I, because in this province especially, falls are really bad for the home. She said, "Well, if he falls, I pick him up if he's okay. If he's not okay, then we have a team meeting to say, what could we have done to prevent this? Should we continue? How should we go ahead?" A really different kind of notion of an approach to risk as well. And one of the things we ended up saying in the technical committee on health standards was said there has to be some tolerance of risk, because life without risk is boring. And it's boring for staff, and it's boring for residents. Of course, in addition to appropriate staffing levels, secure employment, and autonomy that are basic conditions for joy, staff also need decent pay, benefits, and equipment, which we also often forget. That staff in long-term care are paid less than those in hospitals in Ontario indicates the value attached to both the residents and the staff. There's limited recognition that this is skilled work rather than simply something anyone could do by virtue of being female. Indeed, Ontario's new resident care assistants are not required to have any formal care training to do things described such as feeding residents, a term that implies doing something to a resident rather than for or with that resident. Like the challenge of the thin blue line, those thinking that it is a no-brainer to help a resident eat, does anybody use that term? To help a resident eat should have to assist a person with dementia, trouble swallowing, no teeth, and a tendency to lash out if food is cold. A person who also wants to be treated as a person rather than simply fed. I was approached by an administrator at a conference recently who said she really rejected what I was saying about these resident assistants posts only requiring high school education, because she said they had a wonderful resident assistant who was working for them. She did a great job chatting, supporting residents, walking them places, doing all kinds of things with them. And then in the course of her conversation, she happened to mention that this woman had been a certified personal support worker who was injured and could no longer do her full-time job. So she was providing this care. So the formal skills she had used had become assumed rather than recognized. And we also forget those things like walking and chatting and sitting down, having some time with the resident is precisely what brings the full-time staff joy. So now we're taking it away and giving it to someone else. And although we hear a lot about resident-focused strategies, as we did in the quote I gave you from the Ontario Commission on COVID, we hear a lot less about staff-focused plans that consider staff as both a collective and as individuals with needs, values, cultural backgrounds, beliefs, and preferences. Indeed, often the notion is if you focus on anything on staff, you're taking it away from residents, which is, of course, what we're trying to challenge in the conditions of work or the conditions of care. And when we're thinking about these individual and collective needs, we also have to think about gender. We seldom think about gender and the physical environment, for example. Most commonly now, gender is used to conceptualize how biology, embodiment, power, and other social relations influence each other in ways that erase possibilities for binary understanding of human gender identification and gender categories. Yet, as Karen Messing, a Canadian expert on occupational health from a gender perspective, puts it, quote, yes, most physical, social, and psychological characteristics of women and men overlap. Yes, women and men and everyone else should be able to access all jobs. But there are areas where there is little overlap in physical characteristics, where many women and a few others are disproportionately affected by the fact that workplaces are designed for the average XY body. On the basis of this perspective, she argues that, quote, above all, we need to develop ways to protect each other while we struggle together to adapt the workplace to our bodies and our lives, end quote. I can't help thinking about a recent conference I was at a big hotel here in Toronto, and on the stage were 4 big, fat, brown leather chairs. 3 of the speakers were substantially sized white men, and there was a racialized woman on the 4th chair. She couldn't sit up. She kept she would slip down. There was nothing to grab onto. Her legs would come apart, and of course you could see up her skirt because she couldn't hold on to anything. It was just such a visible example of how the equipment makes a difference. And we see this kind of equipment in long-term care homes. We see shelves that are too high that they can't reach, for example. We see we see counters that they can't see over, wheelchairs that are too heavy for them to push, especially on carpets. You know, that it's like in the airport. You wonder, why did they put that carpet in there? You can't pull your suitcase, right? Imagine if you're pushing somebody in a wheelchair and you're not very big physically, right? And we also see lifts that don't go into the bathroom, or toilets that are shoved into the corner, so you can't have 2 people doing a lift at the same time, right? Which is women often, by the way, Karen Messing, the same, I'm going all the time probably. Karen Messing, the same person I just quoted, was very important in Canada in allowing women into the firefighting. And she showed that the tests that required you to lift this way, weights, the notion that you would carry somebody out of a fire that way, discriminated against women. But, and she showed how, you know, you look at women carrying kids, women often carry bigger weights than men do on a daily basis as they lug their children around, right? But if you let the woman do it the way she would felt like doing it, she could do it. And it was very important. We just need the kinds of equipment. In Norway, for instance, they encouraged the women to design their own cart for their housekeeping supplies. They made it smaller and much more efficient, and it could then fit in the bathroom and in other places, reducing their work time, but also fitting their physical needs. Sarah Abdu's thesis in industrial design at Carleton University provides an excellent example of thinking through gender and the environment, as well as about dignity and respect for families, residents, and staff. It's a study of continence care. Now, this is not what you would think of your first thesis topic, perhaps. One that attends to the voices of resident staff and family. She explores how furniture and bathrooms and the overall physical environments can incorporate an understanding of dignity for residents and staff, as well as safety for all of them, while recognizing these gendered patterns. She considers such things as storage, how, because often they pile these diapers out, beside the bed. It's like a big sign, I'm incontinent, that is, it included a place to get rid of the garbage afterwards. It allowed them to move these into the bathroom, but she also considered things like where the bathrooms for the staff were located, because some of these women said, I've had 2 kids and I have to pee a lot, or, I need to be close. I can't run down to a basement 3 stories below to when I have to go to the bathroom. And she considered all of these aspects of the staff, the resident, and the family in a way that redrew what the equipment looked like and what the physical space looked like. But I encourage you actually to look for a thesis. It's at Carleton University in industrial design. There are many other examples of issues that are more common for women than for men. And there's some recognition that women are more likely than men to have responsibility for children. And we do see nursing homes that have put in daycare centers. But there's much less recognition of women's responsibilities for older children, for example, especially in terms of their scheduling and the kinds of ways they might need to adjust as their kids get older. There's also much less recognition that women are less likely to own cars than men. When they do have cars, they need to have a safe place to get in and out of them in the middle of the night when they change shifts. They also are more likely to use public transit, so they need safe spaces to wait for the bus, to get home from the bus. That we need to constantly be thinking of these, what are their lives like? And then how can we address this to change the conditions? Now, it's also true for the small number of men who work in long-term care. You'll see a couple of papers on this on our website in terms of men in long-term care. But we were in one home where first of all, the men are often racialized in homes that are predominantly white residents, and often the family, especially, or the men in the family, will object to their wife being looked after by this guy, right? Or the resident themselves will do so. But they had developed a system where they started gradually introducing the man with a female to start to provide care until they all got used to it, and then they could make the transition, recognizing that, gender can matter. In sum, creating the conditions of work for care means thinking in terms of supporting relationships with residents and families and with other staff. It means recognizing this is skilled work by providing for the development of those skills and for allowing the staff to exercise those skills with trust, training, and teamwork. It also means recognizing the skill, efforts, and responsibilities and working conditions by improving pay and benefits. And it means addressing both individual and collective needs of the gendered populations that provide them. But I can't leave it there. I'm about to wrap up, but I have to talk about profitization and privatization because they can undermine the efforts to create such conditions. Privatization includes the failure to provide sufficient staff and beds in the public system, producing increasing pressure on both staff and families to do unpaid work and to pay for alternative care. The adoption of surveillance and other managerial practices from the for-profit sector is also a form of privatization that limits the conditions I've been describing. Profitization is another form of privatization. One that hands, in some cases, the services, like contracting out the food services, for example, to a for-profit company, and the bed licenses to for-profit companies, and increasingly to for-profit companies that are corporate chains. This is especially the case in Ontario, our province, where 60% of the nursing homes funded by the province are owned by organizations that are for profit. And in those, the staffing levels tend to be lower. More work is done by those with fewer formal skills, and autonomy is limited. So in other words, the conditions that we've just been talking about are least likely to be found in for-profit facilities. None of this is surprising, given that profit comes primarily by selling more and paying less. Given that government controls the number of beds in this province, and that there are not enough beds to fill demands, there are fewer opportunities to sell more or even to pretend that competition would improve quality. Meanwhile, profitization increases pressure against creating the conditions that could promote quality care work, let alone bring joy. Now, recently, the government in this province not only renewed the license of Orchard Villa, the home with had among the highest death rates in the COVID era, and where the military was sent in and did a report that was outrageous. They not only got their license renewed, but extended to more beds. So I will see what happens to the conditions. I still am sometimes hopeful. So I'm going to stop here, so I can hear it from you about how and where you think we can address the conditions of work, doing so in ways that move beyond minimums to consider conditions that make the work not only rewarding, but joyful. So thank you.
Thank you. Oh, I'll sit. Thank you very much, Pat, for this very nuanced and detailed presentation of the research that you have done with your team, and also on the long-term care homes in 5 countries. I would, before anything, I forgot to introduce myself when we started. I'm Ito Peng, and I'm the Director of Center for Global Social Policy, professor here at the University of Toronto Department of Sociology, and also the PI for the Shared Partnership Research Project, Care Economies in Context. So thank you again, very much again, Pat, for your excellent presentation. I would like to now open the floor for any questions, comments, clarifications. You could do it either raising your hand virtually and in person, or you could put it in the chat, the question. So floor is open. Anybody feel free to ask questions, give comments. Well, okay, Nora.
Hi, Nora.
Oh, you have to unmute yourself.
Okay, got it. Pat, of course, I've long thought your work is fascinating, and I have been thinking, as you've talked about things like joy, about some of the work that we're doing on well-being. I think we're using different words for the same kind of thing. You talk a lot about you talk about the conditions for joy being things like what I'd call material well-being, decent pay, decent working conditions, about the importance of good relationships. In your work, what would you say? You talk about context, but in your work with care workers, how do they think about what I might call person-environment fit? Like, what do they say about contexts that are important to them?
They say a lot of things. It depends on, on which country in part, and which groups, because as we've said a number of times, we do everyone who works there, right? The housekeeping staff, the dietary staff. I mean, there's no question that a stable employment is step number one,
Mm,
right? Because if you don't have a real job, that's all you're worrying about right now, right?
mhm,
And another thing is not just this kind of autonomy. Autonomy is really important to them, like the capacity to respond when they think they need it, and that gives them satisfaction as well as, of course, improving the care. But also scheduling. I didn't mention in this contract where I said they offered everyone full employment if they wanted it. They also said, we guarantee you will know your schedule 2 weeks in advance, but also you can switch. You know, if it's a birthday party, you can ask Mary if she would, you know, she'd come in at midnight and you'll come in for, you know, midnight for her next week.
Mhm.
And that too is a form of autonomy, right?
mhm,
Uh,
mhm.
That allows them to get that kind of joy in their lives, right? I mean, the other point I was trying to make is that we forget that these are people, you know, who might have trouble with their housing, who, you know, they might have domestic, you know, that these other things too, how can we support them in that?
Mhm.
In terms of conditions, including housing, right?
Yeah.
We have seen a few places that are really considering supportive housing in the area. And one of the things in this city, in Toronto, housing is very expensive, and a lot of these staff drive for 3 hours after they get off a shift. Well, not quite, but you know, you couldn't Toronto traffic, drive for 3 hours. And you're already wiped, right?
Mhm, mhm.
And so thinking about transit, it's interesting to me. I was just advising on it and in place in Toronto, and this notion of thinking about even where you wait for the bus, especially in a Canadian winter,
Mm,
can make it easier, like, you know,
mhm.
the small and the big things, right? As you said, of course, they want to have decent pay, they want to have benefits, they want to have all that. They want to have more people there and they want to know the people who are there.
Yeah.
That makes a huge difference to them because you really, and we forget that when you've been developed a close relationship with a family and the resident and they die, it's like part of your family dying, right? And allowing them places and time to grieve is really important.
Mm, mm.
And in terms of their health, that you were saying about well-being, we did a study of the 10 homes owned by the city of Toronto. And they were closing the cafeterias in these places, which means that you're working, you can't go out and have lunch. If you're you know, working, I don't have to tell you that, if you're working one of these places, and if in the middle of the night, the only thing you can do is bring the same sandwich to gobble, you know, like there's to go and sit and have a real meal anymore in these places, close to the cafeteria. So it's all of these parts of your life, right?
Mhm.
That and that's partly what I meant about staff-focused care. There's been a lot, increasingly good work, although we haven't necessarily acted on it, about resident-focused care, right? About residents wanting to have choices, they want to have work to the extent of their capacities, they want to, we've been talking about these things in terms of residents. Why aren't we talking them about them in terms of staff at the same time? And I mean, there's a lot of tensions around things like language and cultural practices, etc., that need to be brought out in the open and talked about. You know, sorry, I'm going on and on.
Yeah, no. I think that that's a really good, you know, sort of,
Thank
yeah, I agree with,
Thanks, Mary.
with you, the importance of having not only social, physical, but social you know, social and environmental kind of ecosystem that works for both care workers and the residents. Yeah, I'm also wanted to remind that there's a couple of questions on the chat and the another hand up. So
I can
Ben,
translate.
could you translate?
So we have one from Miyade from Mexico, about what you think the fundamental skills that care workers and care providers should be trained in.
Well, increasingly, they have to be medical, because as I was saying earlier, as we more narrowly defined what a hospital is, if it can't be fixed, and fixed relatively quickly, we're going to kick you out, at least in many of the places we've been in. So you do need medical skills, and certainly we're increasingly people have everything from oxygen to catheter to blah, blah, blah. So you need to know those medical skills that we've heard in many long-term care places. I started working here 30 years ago, and the residents drove up in their car, and it was a different, very different kind of thing. So they need those, but they also need social skills. People die from loneliness and they die from loneliness in long-term care. The Congregate Care Committee that Ito mentioned in the introduction did a study on residents who came in to long-term care without any relative or friend on their admission slip. First of all, they tended to be in fewer health issues than other people. So in part, they got in because there was nobody else to help, right? But when they went in, they were more likely to die. And if the staff need those kinds of social skills. I mean, we were in a wonderful home in Norway where they integrated music into everything, and they trained the staff in using music to do bed care, using music, when they're walking down the hall with the residents. This home had a choir made up of people who were primarily nonverbal, like unbelievable. Like it was, so there's a whole range of skills when we think about on both sides living, right? And what kinds of things make you feel good about living? And anyway, I hope that raises. So I think it's a range of skills, and we tend to think that the chatting to someone, that sitting down with them for 10 minutes while they cry, or listening to their complaints about the cold food and getting them something warm to eat, it is increasingly seen as a waste of time, right? And something you can't measure easily. So get rid of it and then hire this resident assistant, go chat to someone, right? Like if you have 5 minutes, 5 minutes left, go chat to someone. Well, that's not the way it works, Anyway, I hope that addresses some of the question. I think it's and I interviewed a recreation therapist, and one of the questions we often ask people is, anything surprised you about this job? And she said, yeah, I was surprised that I had to help people eat. And all they did was show me a 10-minute video, and I was terrified as a result of helping anybody help eat, because all of the things that can go wrong, that just recognizing how scared, or helping someone dress. I mean, in our wash, wear, and care book, we talk about how clothes are the one thing you take into a nursing home that is about you. It's about your identity, right? Like even your identifying might be ripped jeans, but it's your identity, right? And it's really important for you to have that. But so much of the stuff may be harder to get into. So helping someone help themselves is a really important skill, especially if they're fragile and they have difficulty breathing and a whole lot of other things. So we have to think bigger.
Okay, so thank you. We have 3 more questions.
Okay.
I have in the list Isabel, who has patiently waiting and her hands up, and then followed by Gabriela, who's on the chat, and left a question on the chat, and then Margarita also hands up. So we'll start with Isabel. Yeah, Isabel, go ahead.
Hola, buenas.
Good afternoon, everyone. I'm Isabel Lovrencevich. I'll speak through the translators because I don't speak English. I'm particularly interested in some of the things being said here. I'm from Argentina. Thank you, Pat, for your presentation. I'm absolutely surprised by the situation in long-term care. It doesn't seem like a stretch to say that in some ways it's worse than in Argentina. From what Pat told us, it seems like the human resources in the care sector suffer from a lack of professionalization, unless I misunderstood the translation. For example, Pat told us that a care provider might be with a person and then leave them alone. If they fall down, then they fall down. And the caregiver might be totally overwhelmed because they've only been shown a 15-minute training video in which they were taught how to feed someone, and they're really worried that they might not have the capacity to actually do this task. A logical fear. So my questions are, in Canada, is there a legal certification that care providers have to get in order to work in long-term elder care? And is there career training for home-based care providers? Because in Argentina there is, and our approach to human resource development is not so generalized or fragmented. So I ask, is this the case in Canada? Or is it more like someone comes to an employment agency seeking work as a cleaner, and the agency shows that person a training video and assigns them a caregiving job in a long-term care facility without adequate training?
I'm sorry if I was confusing about my example in Norway. They certainly. The point was they try and keep up people's capacities. And that means pushing people like they do in physiotherapy and other things. But they spend the time trying to do that. Was part of my point on this. Whereas in Canada, if you start to have real trouble walking, instead of them trying to help you continue to walk, they will put you in a wheelchair. That's what we see more frequently happening here. So that was part of my point. My other point was, if issues arrive with as a result of practices of any sort, whether they be this example, then the strategy is not to fill out a report and send it up, but rather to figure out how we can prevent this from happening again. How can we deal with it here? How can we make it better? And my final point was the one about risk, that sometimes that allowing risk may make a huge difference to somebody's life. Of course, you don't want to do risk that may harm someone else.
Sí.
And you certainly want to
No,
limit.
no,
Excuse me, I'd like to clarify something. Of course it's this way. For many years, we've been trying to eliminate the ways in which people who are institutionalized are physically and chemically restrained. But to do so, there have to be norms and regulations. For example, there are groups in Spain and Argentina. One is called SATAR, and another is called La Norma Libera Care. They provide specific guidelines for how to go about withdrawing physical and chemical restraints gradually, so that autonomy can be the rule, rather than us just saying, if the person falls, they fall, so be it. That's why everything has to be done gradually and according to regulations. La Norma Libera Care offers something similar to ISO certification. They train and credential care institutions under a Norma Libera Care certification, which is an official indication that there are no patients or clients in that institution who are being subjected to physical or chemical restraints. It's not just a matter of trying things out in an unstructured manner, because of course, autonomy for patients should be the rule, but without doing harm to anyone. That's why there needs to be a controlled environment with specific guidelines. This is what I'm calling attention to. without a professionalized career track that includes trainings and credentialing for care providers, then everything gets left up to the individual care provider. They might say, I'm empathetic, I'm affectionate, I'll care for you with joy. But sometimes that's just not enough. Caring for elders is a serious profession, and it should be considered as such.
Well, to go back to the training, that in all 6 countries we've studied, registered nurses have very similar training. You know, they are for the most part university trained and certified. All of them have a second kind of level. In Canada, they can be called licensed practical nurses or registered practical nurses. They have fewer years of formal training. Usually it's 2 years instead of 4 years, but it varies a bit across the country. But most of the care in Canada is provided by people who are variously called personal support workers or some variation on that. And historically, they haven't had there's been an incredible variation in the extent to which they were required to have certification. But now all provinces are requiring them to have training that they can vary from 12 months to a year and a half, for instance. And in terms of where it's provided, increasingly it's provided in formal institutions in Canada. But some of it may be provided in training at work. But there's also an increasing move towards something that we have certainly been arguing about, is in continual in-house training for everybody as the changing demands increase. So it's changing in Sweden too. Sweden had a lot of care provided by people that I would, well, let's call them personal support workers, but who didn't have that formal training. But it's really hard to compare across the countries, because in Norway and Sweden, you can take these, you can start in high school to be trained for these. So you may end up with actually more training than if you were doing it after high school, after secondary school. So there's a great deal of variation, but there's, in all of the countries we study, increasing pressure on the one hand to have certification and formal employment required. On the other hand, there's this increasing thing like the resident assistants I was describing, who gets carve off some of the stuff to be done with people without formal training. And there's very different divisions of labor in the 6 countries we're on. Canada has a very detailed division of labor. There's housekeeping staff, there's dietary staff, there is, that each of these categories are very carefully separated. They're not in Norway and Sweden. And so you see, so it's hard to say that it's one thing or the other, but certainly Sweden and Norway are both moving towards more detailed division of labor.
Thank you. We now have 4 more people. So I'm going to ask the question people to keep that question sort of tight and short.
And keep it shorter and answer.
No, your answer is great. I think you're providing a lot of context and comparisons. The next one is chat from Gabriela, and then after that, followed by Margarita, who has been having her hands up, and then Bongai, and then Rinalda. So Gabriela's question. Do you want to read her?
Sure. Gabriela from Oxfam, Canada, thanks you for your presentation, and says, we've observed similar trends in early learning and childcare, particularly concerning the operational funding models across provinces. One example is the budgeting for the minimum number of early childhood educators required. Do you have any recommendations on how we can propose policy alternatives that better support us in achieving these conditions of joy and other fundamental elements like trust, personal judgment, and measured risk?
Lot of big questions.
I wish I had a quick answer to how to create a revolution in the understanding of, and it's part of the point I was trying to make about care for older people, is the notion is that because so much of it has been hidden in the household, we assume that it's unskilled, but also hidden in the household was bad care, right? Like we just assumed that any mother loves her kid, and loving your kid, first of all, is a major question, but secondly, you love your kid, that you do the right thing, that you know how to do stuff, and that you can do it effectively, and just moving beyond that recognition. I'm working with the midwives in Ontario, also a new job evaluation scheme, and convincing how in job evaluation, we have to make these skills visible, first of all, in order for them to be recognized, and then we have to appropriately value them. And the extent to which stuff like knowing how to talk to someone, how to talk to a child, for instance, or talk to someone with dementia is really important. And it's not something that comes naturally, that by virtue of being a woman. And I mean, I think part of the thing we need to do in childcare is do this kind of job evaluation that really begins with, what does a whole day look like, minute by minute by minute, and what do you have to know to do that, and make those skills really visible to start with, because I think so much of what I see around the discussion on childcare is the notion that anybody can look after kids all day. And if you can tell me how to, how to transfer that kind of knowledge to long-term care, I'd be grateful.
Thank you. That's great. So we have about 10 minutes left for this seminar. Margarita, you're next. Margarita, you need to unmute yourself.
Thank you. I am Margarita Garfias from Mexico. I'm 24/7 unpaid caregiver, and I want to congratulate Dr. Pat on her presentation, because very few people actually do make these populations visible. Those who are also secluded in their homes, locked in their homes, such as and the other demographic, which is unvisibilized, is us, basically, those who do the caregiving. So first, as you've mentioned, long-term institutionalized care, do they increase the likelihood of death for people living in these spaces? Then why don't we try to encourage institutionalization, which the United Nations has been speaking about for years now, because being in institutions, often when they go unregulated, or when they go on without the correct legal framework, they are very dangerous for those who are inside, even not only the residents, but the staff, those who need to be there to care for them, as well as collaborative living, open living, which I believe Canada is a country that can allow this to happen, a country that can afford for this to happen. Regarding when a single person decides to encourage an elderly person to stand up and try to walk and try to be them if they fall. Our colleague from Argentina, she was saying it was kind of irresponsible, kind of putting them at risk. I think that the decision should rely on the elderly person themselves, the person undergoing the challenge or not, whether they should be the ones to decide whether to take the challenge and try to walk, even though whatever risks might be, or remain in the wheelchair, even though that might be more comfortable for others, third parties. So that was my idea. Thank you.
I think you're raising all kinds of excellent points. I was on a phone-in program one time where a woman said, both my parents have advanced dementia and I'm under house arrest. Because she said she could not leave, she couldn't go anywhere. And her health was deteriorating. I mean, I'm all for home care, I'm all for people staying in their homes. But I am also interested in making those places called institutions as good as they can be. We've been doing, one of the things we do when we go in these places is say to residents, is there anything better about being here rather than being in your private home? Now that's assuming that they have a private home. And that's assuming they have relatives, right? Because there's lots of people who don't have it. And lots of private homes are abusive, which we also have to think about. But when we ask them, is there anything better about these homes being here? We often get really positive responses. And so we say, why do you think it's better? One of the things we heard was that they feel safe. Now, that may seem strange, as you said, some of these places are not regulated, and in fact, it was huge scandals in these kinds of places that led to regulation in our province. But they said they felt safe. One example a woman gave was that she'd had a stroke. She's insulin dependent diabetic, and she could no longer remember to take her insulin, and they made sure she had her insulin, right? You know, that kind of thing happened. So safety was one. Company, they said, if I was at home, I'd be all by myself. And here I have people, I don't necessarily like them all, but you know, there are some people I like, and they keep me company. The third thing they said was that we have activities. They said, I know people think that we spend all of our time watching television, but if I was at home, that's the only thing I do is watch television. Whereas, you know, we sometimes even go to a ball game, you know, that we get to do other things, and we get to participate in other activities that we would never do if we were living in our private home. And I have to say, the final thing that we heard most commonly from women, I don't have to cook, I don't have to clean the toilet, I don't have to worry all the time about not being able to do all of those essential things about living. So it's true, a lot of the long-term care home, we've been in long-term care homes. We were trying to look for places that would be good examples. And when we were in Texas, we went into 3 that had high quality indicators, where the smell of urine was so strong when we walked in the door, we turned around and walked out. I mean, it's true that there are some of them, but we need to figure out ways to make them as good as they can be. That's been our projects have been called Reimagining Long-Term Care. And we're trying to reimagine them as being as good as they can be. Instead of saying, close them down and send everybody to a private home. But once again, I want to make it very clear, I'm not against people being in their own home, especially if that's a nice, safe place with people.
Yes, thank you. And Margarita just sent a message asking for the list of reference, which we will upload shortly. We still have 3 more questions, but what I on the chat, and we've got only like 5 minutes left, so I'm going to ask Ben to bundle those questions, if it,
Will do.
if you could please bundle them and then perhaps Pat could.
Yeah, so one question coming from Bongai in South Africa, Director of Disability and HIV/AIDS Trust South Africa, is about the psychological toll that caregivers take on in under-resourced care settings. And I think we can tie this one into what yes, Ronalda is asking about as well, which is how can family and unpaid caregivers care for themselves? So self-care. So what might you say about providing access to both self-care and psychological care for people who are doing care work, whether it's paid or unpaid?
Well, a lot of the answers to the how do you do the psychological support is individual therapies or mindfulness or other kinds of strategies, none of which I'm opposed to, but I think they suggest that the problem's yours and not the lack of supports for you to provide this kind of care. And that's, I think what we have to look at both. So yeah, sure, individual support schemes for specific issues with specific people, but I also think we have to think in terms of the conditions of work that allow them in the ways I was talking about earlier. And the second half of the question was about
Self-care for family.
Yeah.
caregivers.
And I mean, there are ways we could, if people are going to stay in their home, there are ways we can do things like ensure there's respite care, ensure that, but we can't, as a society, provide paid 24-hour care for everybody who needs it at home, right? So we need more collective responses. One of the things that's starting to happen in the city of Toronto, for instance, are places called NORCs, naturally occurring retirement communities, where these big condos that are developing, people are organizing within them to provide some kinds of care services, like trying to help each other when you never get out of the house. If someone who could just, is able to go and sit for a while in your place so that you can just run around the block or something. So we can do some communal supports. I mean, I certainly think that we as a public are responsible collectively through our public services. But I also think that there are other ways we can provide supports as individuals. But again, I think we have, as we start our book on the labor force crisis, we start with the assumption of that we need the right to care. The right to care is about the right to access to quality care and the right to provide quality care. Go into a long story and I shouldn't. One of the things is I think people should have the right to say no. Those people who are expected to provide care should have the right to say no. And then we should have some other options available. Vito and I were just talking earlier about asking women to provide care to a spouse who has been abusive to them all their lives. Like, do we require them to do that, or do we give them the right to say, screw that, I'm not doing it? So there are so many parts and pieces to take on, but I'm hopeful that we can make collective care in various forms more accessible, and that in doing so, the people who are providing that care are able to get rewards and joy.
That's a great way to conclude. Thank you so much. And my apologies, we have that time limit. And we try to, I know, great presentations like this always end up, bringing more people to ask questions and comments. So we could continue this conversation. But yeah, But I just, but since the time's up, please feel free to send us, if you have more comments and questions into our website, and we will try our best to communicate and answer. Also, please, let us know if you would like to present something in our seminars in future. If you have project, whether it's in Spanish or English, we will try to find ways to accommodate. So with that, I want to thank everybody for coming, joining us for this really fascinating and wonderful presentation by Professor.
And thank you to everyone from me.
Yeah, and also thank you very much for the translators. I know it's a lot of work to do simultaneous translations, so much appreciated. So with that, thank you, everybody, and hopefully we'll see you again next time at the next seminar. Bye for now.
Thank you. I talked too much.